Okay, so the second question that we had this week was on lumbar radiculopathy and treating radiculopathy into the legs. And so what I thought I'd do is show you how I evaluate for lumbar radiculopathy and how my evaluation helps to dictate treatment. So this evaluation is kind of a hybrid of a McKinsey assessment, which looks at directional preference of movement and how movement is influencing symptoms. So I'm going to take myself through the exam and kind of talk you through what I would do. So in this example, I'm the patient as well as the therapist. So if I'm when the patient stands, the first thing I want to do is say, make me a map of your pain. Where are you feeling pain right now in this moment? And so they'll say, I'm feeling it here. It's kind of going down my leg like this. And I want to have an idea of how much surface area the pain has. The second question I have for the patient is, how intense is that pain on a scale of 0 to 10? So I have kind of the geographical area, and then I have the intensity. And then I want to see how repeated movement influences the experience of pain, both in intensity and in geography. So the first set of movements we're going to do is forward flexion. And I'm going to have the patient go all the way forward as far as they can. Doesn't matter if it's uncomfortable. I'm curious if it hurts to flex. But what I really want to see is how that pain changes after about 8 to 10 repetitions of forward flexion. So I'm going to do that for you now. And the patient will just go back and forth. Okay, so say that was 8 times. Then you want to check back and see, okay, what happened here? Did this get better, worse, or no change? And there's 2 things we're measuring if it got better. We want to see the geographical area shrink, and we want to see the pain level go down. Now, what we will typically expect with forward flexion in someone with radiculopathy is that will make it worse. Someone with stenosis, forward bending might make it better. Let's talk about that for a minute. So oftentimes radiculopathies are caused by bulging disc or stenosis. And bulging discs often respond better to extension. The theory there is that extension regulates the pressure on the disc so the bulge isn't pressing on the nerve or on the annulus as much. Where forward flexion is going to put a little bit more pressure through the disc in terms of an anterior-posterior derangement, but it opens up the neural foramen and it opens up the facet joints. So someone with radiculopathy from stenosis might do better with flexion, where someone with radiculopathy from maybe a disc bulge might do better with extension. So you're going to do your 10 repeated motions and then check back in with that original pain geographical area and pain intensity. Now we're going to move into extension. So we checked flexion and we recorded what the outcome was. Better, worse, no change with those 2 variables. So now extension, you're going to ask the patient to support themselves with their hands on their pelvis or their hips and take a back bend. And that might be uncomfortable, right? That might cause some pain, but we're not really interested in what's happening during the motion. We're more interested in what happens after the motion. So we'll take 10 good back bends. And what you might see is someone trying to do a back bend like this. Okay, so if I'm just moving my hips forward, I'm really not extending at my spine. So you want to make sure they're getting back and actually extending their lower back. Okay, not really coming forward a lot with their hips. Okay, after 10 extensions, what happens? Does the pain get better, worse, no change? Does the geographical area shrink? Or does the intensity go up or go down? From there, we have 2 more motions. We're going to do side gliding. And side gliding can be really telling, especially if there's one-sided pain or the pain is quite lateral in the radiculopathy. So I'm going to take you over to the wall now. And I use the wall to do side gliding. And I have the patient stand at the wall with their forearm against the wall and hand on the hip. And then they're just going to drop their pelvis toward the wall. So this would be side gliding. What's happening here is that I'm pinching on this side, but I'm opening on this side. And so if I had radiculopathy over here from a disc, I would expect this motion of opening to be worse because the disc bulge is going to travel this way. However, if I have stenosis over here, this might help my radiculopathy feel better. So we're curious if it gets better or worse after 10 repetitions. So then I have the person stand, reevaluate that pain, better, worse, or no change, and then we'll repeat to the other side. Okay, so that's the standing assessment. And I'm gathering information, I'm putting it together, I'm looking at patterns, seeing what movements make this person's pain experience better or worse. Now, one thing I'll say about standing extension is that it's often not as effective as reducing symptoms as unloaded extension or extension in lying. So we're going to go through that next in just a minute, actually. First, we're going to move into the seated assessment. So in the seated assessment, you want to look at your myotomes, dermatomes. You're going to do sensation screening. You're going to do your reflexes. You can check standing, calf strength, having the person come up and down 10 times on their tippy toes, looking to see if there's a difference in strength on either side. You can look at dorsiflexion strength, great toe extension strength. I find all of those really helpful in ruling in or out if there's actual nerve compression. Then I want to see if there's a positive slump test. So the neuro exam, the dermatome exam, sensory exam, reflexes, all tell me the severity of this problem. So if the neuro exam is affected, then I know I'm at a greater level of severity. Whereas if it's just movement patterns, that's a lesser severity. But I also want to know if there's tension along the sciatic nerve. So we do this with the slump test. So slump test looks like this. You're going to ask the patient to extend the leg. Flex the toe toward them. Does that produce any radiculopathy symptoms? Does that reproduce their pain? And then I say, now I want you to take your nose to your knee. So tuck your chin and roll down, take your nose to your knee. Does that make your symptoms worse? So if that makes their symptoms worse and reproduces their symptoms, that tells me there's some compression on that sciatic nerve, whether it's coming from like piriformis or hamstrings or spine. I might not be so sure. However, the slump test is a great retest option to see if your intervention is is helpful. So we'll go through that in a second. Okay, now I'm going to do the other side, and I always do the non-painful side first, so they know what normal should be. Extend the leg out, flex the foot. See, my foot is flexed, and then nose towards the knee. I'm going to round myself, and as the therapist, I'm looking at range of motion as well as pain generation with the slump test. So now we're going to move into our prone extension maneuver. So again, I want to know, okay, patient, what's the geography of your pain and intensity of your pain? Because we're about to go into another repeated motion intervention, and I want to know if this is going to help. So if your patient is very severe and in a lot of pain, I would start with a pillow or two under their pelvis. And they can just come into like a prone lying. And sometimes just prone lying is enough to decrease symptoms. So prone lying would be like option 1. Option 2 is going to be your Sphinx pose. So coming onto your elbows, trying to keep the butt really relaxed, because when you squeeze the butt, that's going to compress the spine. You want the spine really relaxed. So Sphinx pose for a couple minutes. And come on down, relax. And then we can start a little baby press up. And you want the patient to be able to press up until they feel a pinch in their back. That pinch is important. So really flexible people like me are going to have to go further to get to the pinch. Really stiff people probably don't have to go very far at all. But you're going to do 10 repetitions of prone extension with or without pillows to the pinch. Okay, so pretend I did 10. Then I'm going to have the patient stand back up and check back in with their pain geography and their pain intensity. What happened from doing prone press-ups? Did that make the intensity worse? For stenosis, that's probably going to make them worse. Did it make it better? For disc patients, it's probably going to make them better. No change, we move on. If there's been no change, we either want to add more pressure to the extension, or we want to change up the direction. Okay? So if the person had like the lateral shift that was helpful, we can add in a little bit of that lateral movement to help support what's happening in extension. So if extension was no change, didn't get better, didn't get worse, we either want to add more pressure or we want to add a lateral direction if the person responded to the standing lateral glide. So let's talk about what that looks like. So first of all, more pressure, take the pillow away. Second, add some blocks or books under the person's hands. If they're very flexible and they haven't gotten to the pinch, like me, you could add some blocks. So now they're going to come up and have a little bit more range of motion because their hands are higher. Now I definitely get a pinch there. Okay, so option 1, we add pressure. Option 2, we change direction. So that can look 2 ways. Number 1, I can go into the side glide that helped me. So I just take my hips, I bop them over into the side glide that helped. And then I do my extensions with my pelvis in that side glide. Or I keep my pelvis straight And I just look over the shoulder of the leg with the radiculopathy. So I just kind of turn towards the leg that is hurting. So come on up, and then a little baby twist, come back and relax. So then I want to check again, was that helpful? And I can check with pain geography, pain intensity, but I could also come back to my slump test or my strength tests if they were positive, because they should be better if I am prescribing the right direction of movement. So then you take all that data and you say to your patient, this is the movement strategy that changed your symptoms the best. Whether it was extension, whether it was side gliding, or flexion. We haven't talked about flexion. Let me come back around to that. So if flexion made your patient better, then there's a couple different ways you can do repeated flexion. One is in sitting, and you can have the patient roll down and do some seated flexion. This feels very nice. And this is quite good for people with stenosis because they want to sit, they're tired, their back hurts. And so opening up the facets will feel really good for them in seated flexion. They can also do supine flexion. Where they're taking the knees into the chest and doing repeated flexion like this. And that also can reduce symptoms. So how do we use that information then? We use that information to prescribe movement. And if the person is very severe, in a lot of pain, or very acute, I would repeat the prescribed movement often, up to once an hour. If the person's more chronic, not in as much pain, they could probably use the repeated motion 3 to 5 times a day. You want to do about 10 repetitions of the motion that you prescribe, and you want to encourage the patient to be aware of retest options, right? That they should be monitoring either their pain or their slump test or their strength, and making sure that the intervention that you prescribed is heading them in the right direction, which would be less pain and improved function. So I think that's everything that I wanted to talk about with that. Just remember, it might take a little while. You might have to do some problem solving and some trial and error, but I think that applying these concepts will be really helpful.